them at. I'm going to present this to you in any sort of format is challenging. So I picked the way the government presented it to you. I know, right? We're going to go with, well, yes. Let's go. Clicker, where do I point the clicker? There we go. We're going to, I guess I'm gonna have to go back here so I don't have to crane my neck so I can actually see what I'm talking about. We're going to talk about the key items that surveyors look at, the things that you have to do, and maybe some tools that you can keep in place. I'm not going to read slides. I am not a slide reader. You don't want me to read slides. These slides will be available to you if you want to read them. Just know that if you're coming in the program or you've been in the program for 10 years, they expect you to know all this and they expect you to comply with all of this. So let's get started. What am I supposed to comply with? Okay, you got the CFR, CMS Form 30, State Operating Manual, OSHA, your deeming entity if you have one of those, and the 94-page Appendix G. Not a lot, nothing. All right, so what we're going to do is we're going to hit the highlights. We're going to hit the things that, like I'll walk into a clinic and we talked about it last week. She and I have a spidey sense because we've walked in so many clinics and everybody's like, my clinic's clean. There's nothing. And I'm like, there's the expired that you just know it. So what gets my best clinics? The ones that have it all together. So we're going to kind of talk about some of those. And then let's take a poll, at least in this room. Who is deemed under the state of Michigan? Okay, so we've got a group over 2 groups, the state, the compliance team. Quad A. No quad A in this, quad A. Okay, so we've got a little bit, and each one of those has a slight nuances, and we'll try to go into those. Just know that when you do get surveyed, there are things that are condition level, meaning do not pass go, do not collect 200, you guys play Monopoly, you know, that's it. And then there's standard level. Just know that if you get enough standard level, it elevates it to a condition level, okay? 42 CFR is the one that I'm going to use as our roadmap today. The first few things are talking about just the conditions that you have to do. So first of all, there's a difference between I'm trying to get certified and I'm trying to be recertified. Talked about the surveying entities. Again, I'm not following slides here. I just think that will put all of you to sleep. 1 to 4, I'm not going through. So 42 CFR, Code of Federal Regulations, 1 to 4. So it's like this big triangle, okay? So the federal regulations are at the top, and then you have interpretive guidelines, you have Appendix G, but it all goes back to the Code of Federal Regulations. And that's why some of these things that you hear out in the community that they're trying to change, like maybe they're trying to get the lab to be, what was the word they used, prompt access instead of must be in your 4 walls. They're trying to get that done. They can't just do it in the guidance because it's in the law. So it literally takes an act of Congress to do it if it's in this law. So 491 has 12 sections. 1 to 4, we're not going to go over its purpose and scope. What are the definitions? How do you get certified? You must comply. Okay, we're going to skip into the meat of this. We go to number 5, and I've got till 10:15, right? Yes. So the first thing is, if you're coming into the program, you have to be in a HPSA, in a current HPSA. But note the stars. If you are already certified, is that what we're saying? Yes. And your HPSA is dropped, you are grandfathered in. If you move across the street, though, you could lose. And I say that, you have to check your HPSA again. So where you are grandfathered in. even if your county loses its HIPSA. But if your county loses its HIPSA and you move and you're still in a county without a HIPSA, be careful, because you will lose your designation. The other thing is, and we've seen it, let's just say this black tape right here on the floor is the highway. I'm RHC and I need to move. We've had to move over here. They tell us afterwards, oh, it's called before. We can save you headaches before. They move over here, already made the move. But this side of the street's it's not in HIPSA for whatever reason. And they lost their RHC designation. So you're grandfathered in, even if your area loses its HIPSA. But if you move, or if you're starting a new one, it has to be in a current HIPSA. So what do I need to have? Ownership page, copy of your current HIPSA if you have it, or the HIPSA if you were certified. These are just some documents that you're going to want to keep on hand. This is more for your new RHCs. So 5 is where I have to be. I have to be in a health professional shortage area, rural. There are definitions on that, and we can run addresses for you if you need others. I'm sure Jill has that capability, or she knows someone that does. Okay, so 5 is where we're located. 6, this is where the meat is. And again, how do we go through this? How do I arrange this? 6 is where it really all is, but it's in the middle of the regulations. We're just going to pick the way the government did it. It's just that it's half dozen one, 6 another. Physical, I'm 491.6. When you see this RHC regulation on the screen, this is how it's written. This is the exact verbiage that's in the law. What I've tried to do is anything bolded would be or red would be something that I have brought out. When the regulations went into guidance and went into the state operating manual, they really put a lot of emphasis on safety of patients, preventative maintenance, but this is where it's coming from in the law. They want all essential mechanical, electrical, and patient equipment maintained, drugs and biologicals appropriately stored, and premises clean and orderly. Now, this is the regulations. So how do we get that done? Well, first of all, this is where that requirement that you have your maintenance log. So when we go into a clinic and you guys are doing self audits of your clinic, you've got to be sure that you have those little stickers or a log, I guess, if it's both stickers, that you can prove that once a year, because remember, we're back up here. Number 1, this is the law. All essential mechanical, electrical, and patient care equipment is maintained. And how do they look at that? They want to see that you had biomedical on your equipment and at least an electrical inspection. What we like to say is anything that touches a patient needs to be electrical inspected. That includes your beds that are plugged into the wall, and anything that measures a patient, you need to have that biomedical once a year. They're going to look at your policies, and I am not going to talk about policies because let me just tell you, I'm going to crown the queen right here. This is the queen of all things policies, chart reviews, and she's going to go into that this afternoon. So I'm going to brush over that, but don't think you're not going to get it. I'm going to let Tressa handle that. Cleaning and disinfecting. That's why they look at the cleaning logs. That's why they look at your policies to be sure that you have a cleaning policy. How are you cleaning the chairs in your waiting room? I'll walk into a waiting room and the first thing I see is cloth chairs, which we've all gotten rid of those, most of them during COVID. But they want to know, how are you cleaning? Do you have, please tell me no one has the teddy bears in their clinic, right? Everybody's gotten rid of those during COVID. I think we kind of moved away from some of those, but before that, I went into one in Texas. Was it you or me that went? I'm not even sure. It was great though, and I hated to tell them they couldn't have it, but it was a saddle with like a plush horse, and that's where the kids would be examined. You know, it's Texas. They they get into their work. But of course they do here. Isn't it Fair Week in a lot of the counties around here? Yes, yes. Chris, the CEO of our company, she had her whole family is at the Waco County Fair. Yeah, this week. So I've heard all about cleaning the pigs and the showing it's all happening today. But which they laugh at me because I'm not a pig girl. I love them. Just yeah. But we need to be sure that the clinic is safe, that the clinic is clean. How do we sanitize? They want to see your policies. They want to see that, for instance, I may walk in and let's just say I'm your MA. Well, they're going to ask me, what is the wet time on that sandy wipe, on that caddy wipe rather? They want to be sure that the caddy wipe they're using is the one that kills the big 3 viruses, that they're going to be looking at things in your facility for cleaning and disinfecting. The big one that I have seen, tell you, spore checks. Who's doing autoclaving here? Anyone got 1, 2 autoclaving? I would say at least 50% of the clinics that we go in right now that have autoclaves are not doing weekly spore checks, where you send it off either to the hospital infection control post or to a contracted entity and get those spore reports back. And when you do that, you have to be able to identify, let's say you got back a failed spore report, you have to be able to identify which instruments were in that failed batch. So you need batch logs, you need numbers on all of those. Disposables are best. But if you're going to, I recommend pull out that manufacturer's guideline. Read it, know it. How often are you supposed to change the water? How often are you supposed to clean that rubber ring? Maintain it. How do you maintain it? What are your spore check requirements? And then the other thing, and I hate to say this, but just because someone tells you they're doing it doesn't mean they're doing it. Everybody nod, they understand. Dig deep. Find the spore reports for the last 6 months. Don't just let them tell you it's in that folder, because I've had that happen before. You open the folder and it's just not there. This is important. This is one of those, remember we talked about condition and standard. Condition. Improper maintenance, improper cleaning of your medical equipment, it can be condition. And then how are you handling your drugs and biologicals? Okay, so I'll tell you the things that are catching my best clinics right now. Top 2 are sterile water and sterile gauze. They are single use. If you see a circle with the number 2 in it and a line through it, that means it is, don't use it twice, it is single use. And we've even had arguments, well, we just pull the gauze out and we cut it with, we don't, because if you want to keep it, first of all, just give it to the patient. I'm talking about those brown Curad kind of bottles, those brown bottles, the strips, also the ones that are in the tray. I mean, take it out of the tray and put, if you don't want to use it as sterile again, that's not my preference. My preference is you just give it to the patient, but you can't put that tray back in because it is a single use tray. The other thing is, don't buy those large bottles of sterile water. They are single use. Even though you might say, well, I'm not going to use it as sterile again. We're just going to use, no, because a surveyor is going to come in and say, that is a single use item that you have put back. What is worse than that's the one that's catching even my best clinics, sterile water, sterile gauze. What is worse than that would be is if you put back a single use vial. That is condition level. We actually had it was a Michigan clinic where the surveyor passed it and it was overturned at CMS Baltimore. And the clinic failed for one single-use injectable vial that was dated and put back because it doesn't have preservatives in it. You can't use a single-use vial. It's a one and done. The rest of the vials have to be open dated. If you pop that cap on an injectable, open date, this is one of those nuances for rural health clinics, where JCO is expiration. This rural health clinic is open dated. How many days, ladies and gentlemen? 28 days. Now, I have found through COVID and deep digging that the polio vaccine is actually good until its expiration date. Well, why is that? That's so strange. That's so strange to me. I was like, we always had this blanket rule, 28 days, 28 days, 28 days. The manufacturer's guidelines can trump anything. They override. So if the manufacturer's guidelines say, now on the polio vaccine, because it was just during COVID, people weren't getting vaccines the same rates and levels as they were and as they are going forward. And so instead of wasting them, they did the research. Come to find out, the CDC website even says that you can do this. So you really want to if you're going to do that, you better dig in and print the documentation and have it if it's something. And it just needs to be very, very clear to your staff, because it's just such an easy thing to miss if you tell them, oh, but this one, and there may be a reason for it because it's very expensive and you found the documentation, but be very, very clear. I would even put signs. Polio is the only one that we can, on your fridge. So the policies for storing drugs and biologicals. Make sure that you have routes of egress. Do you have floor plans up? I'm just kind of telling you the things that are catching my foot, the things that we're writing on mock surveys, and Tressa she's out there all day, every day doing these, because that's what this is for, right? This is practice management. You guys, we're going to read you the regs and tell you what you have to do, but then we're going to tell you, oh, watch out for this. These are the things that are catching people, that are tripping them up. And not having floor plans with those routes of egress on them, not having an SDS book. Everybody knows what an SDS book is, right? With the chemicals and, okay. Policies, which again, I'm gonna let Tressa get into. Does everyone have the annual training? Current BLS certificates? Do you have a policy for samples? Who does samples here? You do formula. Your formula has to be on that sample log. Why? Because sometimes there's recalls. We've even seen it, which caused the latest debacle. And I have a daughter and I have a young grandchild, so I know the struggles that moms are going through with formula. But if it's a recall and you gave that formula out, you need to be able to call that mom. If there's a recall on the drug you gave out, just keep the name, the lot number, and then you gave it to the lot number, to where if there is a recall that you can call that patient. They can be in your EMR, and the EMRs are getting more and more sophisticated, but you have to be able to run a report. If you have the ability to do that, that's fine. If not, we'll go old school paper logs. Evidence of proficiency testing. So part of your training, that's another thing that we've seen lately, is more in the smaller clinics, not so much in the hospital settings, or hospital-based, they have more robust programs. But you have to do proficiency testing on those lab tests if you have your MAs doing those things every year. You have to keep control logs and proficiency testing when it comes to the labs. Some more little additional tidbits. Make sure that your refrigerator's labeled. We like to say food only, meds only, lab only. I did have a clinic that just really challenged me on the, wait a minute, can I not put labs in my med fridge? If you have to do it, you have no other space in your clinic, make sure it is on the bottom. If that's where you have to be, you're in just that small and that tight of a space, your labs have to be at the very bottom. And she did find OSHA documentation that said you could do that. Not my recommendation, and that's where we get to recommended versus required, okay? Because I'm going to tell you some things that, like, as you've heard it today, I recommend that you just throw everything away after 28 days. Is it required on polio? It is not. Is it good practice? It is. The same with the labs at the bottom of the fridge. I recommend you don't. But is it required? No. You can actually put some lab samples at the bottom, but it's going to have to be at the bottom where it could not have a spillage. Yeah, not recommended. Check periodically. I was in actually Georgia, which is where I live. I was in a clinic down there a few years back, and everything's clearly labeled. Meds only. Meds only in the freezer. Had a Lunchable and ice cream. You can't make this stuff up. Do not unplug signs at the wall and on the fridges. It's part of the emergency plan that Tressa will touch on, is a policy on how you're going to handle power outages. Any other, I'm going to ask Tressa, any other tidbits, because we're just really talking about this section 6 is talking about how your clinic is set up.
I think the biggest thing that's been brought to the forefront this last year. Oh, thank you.
One of the clinics came to us because they almost had an immediate jeopardy deficiency because of cold sterilization of instruments versus having some heat component through the autoclave. And as Julie mentioned, disposable only is your best path towards compliance. Most clinics are sending it to the hospital for sterilization and bringing it back, making sure that they're checking packaging that it's been appropriately sterilized. If you do have an autoclave, I recommend doing competency of the staff who are running that it matches what the manufacturer guidelines are. And then cold sterilization, please do not do that first. If you do have to, go back, look at the disinfectant, making sure that it's actually a sterilant, and then follow through on ventilation requirements, staff PPE requirements, processing requirements, documentation. There is a lot of moving pieces within that. So instruments is probably one of the biggest areas where we've seen a microscope because it is such a patient safety concern. That would be
Right, infection control, just across the board, infection control.
Yes.
Yeah, we've seen it. And that's back where it's like required versus recommended. Can you do cold sterilization? I don't want to even say yes. Is it required to have an autoclave? No. Is it required to have disposals? No. But if you're going to have an autoclave, there's a lot of steps you have to go through. And I think if I'm thinking through, and again, I'm just throwing a lot of what gets my best clinics actually this morning, is I will walk into an area where, okay, they're just scrubbed, maybe they send them off to the hospital, but you're going to have goggles and gloves in that area as they scrub. You do not want them scrubbing without goggles on. Make sure that they're right there for the staff to use. I think the other things that I'm seeing from a physical standpoint is, we live in this, unfortunately, we live in this area where we have to talk active shooters. And so one of the things that we're seeing is security. Okay. I know that the staff wants that back door open so that they can come in. No. We were in a clinic last week that, I don't know if Michelle told you this story or not, but they don't have the barriers. It's just this beautiful, beautiful large facility. And they've got a lot of human barriers. but they just don't have barrier, they don't have those physical door locks, which that's recommended, it's not required. Okay, but if you don't have that lock between the waiting room and your patient flow areas, again, recommended, not required. If you don't, then you are going to have some sort of alternate for them. What I'm telling them is, okay, you've got a lot of human barriers. I still don't know if they'll pass with this because they're going to be a new clinic. But you're going to have to explain to a surveyor how you keep your patients safe from the angry daddy that wants back, from the angry patient that wants meds, from just the angry, this happened to be someone had, I don't remember the whole story, someone had stolen something in the building next door, comes running into their clinic, huge clinic, we're talking what, 40 exam rooms, I mean, huge pods, was able to run in, and they have a security guard, there's no physical barriers, was able to run through all the pods, out a door, and the police got him because at least the external doors were locked. They couldn't get back in. So at that point, they were able to lock everything down, and he was out. Or if you have it where you just don't know someone coming in, even if you have it secure, if you got that back door unlocked for people to come in and out, or I've seen it propped open in smaller rural clinics. Michigan, we like August here, right? You have to secure your building. Recommended versus required. If you don't have those locks, you need to show how are you going to deal with a situation like what I just described. Any of those situations. And in today's environment, it's really higher on the required spectrum, if there's a spectrum of it. Because again, I don't know that this clinic will pass without erecting some walls. I just don't know at this point. But the human barriers are there. So if you don't have physical barriers, what are your human barriers? What are you doing? How are you getting it done? Anything else on physical that anyone wants to share about that they've seen surveyors talk about in their clinics? Has anyone had a surveyor come in the last since COVID? You have? 2 of you guys. Did you get anything you want to share? I don't want to get into your business as far as findings or anything, but anything that surprised you that they talked about and asked for?
There's a big thing about bringing I mean, that was actually only my name was that. So our company said we needed to do reviews, employee reviews every 3 years. The RHC requires them annually. So we had to change the whole company's policy so that it was done annually. And we were able to be in compliance. We were already in the process of doing them. But with COVID happening, there was 1 year that we didn't have that compliance. So
Who are you serving by?
Aaron,
The state.
state.
And so that gets back to who you're surveyed by. So the state of Michigan, so everyone understands, had a surveyor come into their clinic and correct me if I'm not saying this, required annual employee evaluations. Okay. So if you're a Michigan clinic by the state, you might want to go back and check that, especially during the COVID era. Now, some of the deeming entities will let you follow your policy, but most of them, I think they're all on an annual basis as well.
And they have their own HR checklist. And so that would define exactly what your expectation is.
She's saying that the TCT and Quad A have their own checklists that define what they need from you. Okay, so we've talked about the physical plant. We're gonna have barriers to protect our patients. We are going to secure our building. We are going to make sure that there's no Lunchables in the refrigerator. We are going to Make sure I'm back. Oh, I was going backwards. Do you
The
know-
other thing we haven't mentioned the physical plant is, especially with the opioid crisis, the way it has been, the security of sharps is really heightened in.
So Tressa said that with the opioid crisis, that the security of sharps. So, okay, forgive me if you've already heard me say this, because this is something I could preach. I am a boil it down kind of girl. Anyone that's met me, it's like, I try to take this stuff, regulations, 94 pages, and just tell me what I need to know. Just boil it down for me. Okay, so when I walk into a clinic, this is how I review it. There are 4 things. Thank you for bringing that up. What she knows. Bring me down the path. 4 things in my mind that have to be locked unless they are in a manned nurses station, always manned nurses station, or in the line of sight, always in the line of sight of employees. PHI, sharps, drugs and biologicals, and chemicals, bleaches, instrument cleaning. So when I walk into a space, it makes it very easy for me to audit that space. The first thing I would say is this space locked? Does this room stay locked when patients, can patients get in here? Can they wander in here? Is there any chance they can wander in here? If so, if it's unlocked or they could wander in there, okay, providers' offices around the corner, then you have to lock PHI, sharps, drugs and biologicals, and chemicals. The only places I would leave them unlocked is if you were in one of those clinics that has 10 MAs, 8 MAs, and there's always something there. Maybe you could leave those cabinets unlocked. But if there is a chance that a patient could be walking out looking for the restroom and get into a space, are any of those 4 things accessible to that patient? You look at it from safety, especially sharp. Okay, so procedure rooms are big with that, because they want to leave. Procedure rooms and labs are probably the place that I see that a lot, because they'll want to leave the instruments unlocked, like in drawers. And my question then is the patient left alone in here to change clothes? Yes. Is there a risk in this mental health crisis that we're having as a country that they might want to hurt themselves with one of those sharps? Are you putting your entity, I mean, there's that, let alone, I had a clinic that just told me that their medical supply cost went dramatically down when they took the medical supplies out of the exam rooms. It just is what it is. But if procedure rooms and labs, if there's any chance that a patient could be there by themselves. All right, what do we say, ladies, gentlemen? Throwing me off. You're the one guy here. Go, 2. Sharps, PHI, chemicals, drugs and biologicals. And that's, nobody told me that, it's not written anywhere that way. I'm just saying I've read all this stuff. And that's how my mind filtered this. And I'm not going to get any more complex than that because I have too much complexity in my life as it is. So we're going to go on to 8, because again, there's 12, but she's going to cover 11 and 12. And 10, yes. So they've told you where you have to be. They've told you how to set up your building, what kind of things you need to have in place to keep your folks secure. Then they go down to just some things you have to do to be an RHC. It has to be under the medical direction of a physician. You have to have a medical director. And be sure all your folks know who that medical director is, because it's not always the most popular doctor. It's not always the doctor that's most helpful. Because someone might ask them, who is your medical director? And they want to say Dr. Judy when it's really Dr. Frank, or vice versa.
We do have a question in the chat.
Yeah.
And it said, if we missed a deadline, how would we document that? For example, if we were late with annual performance reviews or the lab competencies, they were done at 15 months instead of 12 months.
Okay, so she said, if they miss a deadline such as competencies, such as the HR reviews. And again, this is just me boiling it down what I would do. What I would do is do a self-report. So I would write a memo to myself. I would write a memo to myself, to my drawer, that on today, we have identified a deficiency in our process and have missed this. It should have been done here. Here's the process we put in place to fix it. Here, almost like a plan of correction that you would write for a surveyor. When it was identified, what is your plan going forward to make sure it doesn't happen again? When are you going to have it corrected by? It's not something you've got to, at that level. If you're just talking about complete reviews, that's not like a reportable incident. But if anyone comes in and they see you didn't get it done, you can pull that out of your and say, yes, we know that it's an and you look really good. Because you've identified it, you've written an internal plan of correction, you got it corrected, and you have a plan going forward on how you're gonna not have that happen again. Does that answer that?
Yes, and then one more question. Can we store pap smear devices in the exam room?
Okay, pap smear devices. I'm going to take that into two types. There's the speculums, and then there's the pinprick. So speculums, yes, leave them in the packaging or leave it, because I had a doctor, oh my goodness, I want to say New Mexico, she and I, or well, I didn't leave it there, I just let her. But she wanted metal ones uncovered in the drawer, and we were like, you can't. You don't know what patients are going to be in there and contaminate all of that. We finally got her to agree to at least leave them in the packs. Those can be in the bags, whether they're the plastic ones inside packaging or the autoclave ones that in unbroken packaging. The pap smears have chemicals in them. Now, it's not a chemical that we need to necessarily lock, but we don't want it in the reach of a child. So that goes back to when you're looking at your facility. The other thing I think that I like to do, I know Tressa does as well, we're both mothers, and I now have a granddaughter, and by the way, one on the way. Another one, number two. That we look at it from the eyes of a child. What, because we know the mamas are bringing in, the daddies are bringing in their children, and what are they going to get into, and is that safe? And when you look at pap smear, the chemicals, it does have chemicals, something that if they looks like a nice little cup to them, that would be it. So we're going to put that in these cabinets. So the pap smear tubs, if you will, I'm sure there's a better name for that. I'm a CPA by trade, so is going to go up in the cabinet. And the other things, we just want to be sure that they're not unwrapped. Okay, anything else? Okay, anything else on, just some questions that what would I do, or what would Tressa do, or what have we seen? Okay. So we are now on the things that you have to just keep up with paperwork wise. This is the regulation. Remember, this is the Congress passed this, which we'll leave that for a discussion for another day. You have to disclose the name of your owners, the person that's responsible for your medical direction, and you can do that through your policy manual. The only thing I see on a provider base is the patient needs to know what hospital they're entering. So, especially when it comes to labs, because they're going to get bills from your hospital. So you just want to be sure that your signage, if you are Main Street USA, whatever, clinic, and you're owned by ABC Hospital, you just need to say that somewhere. It can either be in your signage, your welcome package that they're filling out, but you need to disclose who owns you, so that the patient knows what hospital they may get bills from, especially from the lab perspective. The staffing things that you have to do, everyone knows you have to have at least one APP. 50% of the time you are open. That is not 50%. That is not just the 0.5 FTE. We were in a clinic not that long ago. They were open 8 to 8, 7 days a week. So do that math. Whatever those hours are, divide that by 2, and that's the amount of hours you have to have your nurse practitioner or your PA. It is not a 0.5 FTE. It is half of the time that your clinic is open. And it's only, you only have to have one. You could have it, and we have them. 10 docs. You have to have at least one. This is just one of those boxes you have to check to be a rural health clinic. You have to have a physician that is your medical director. Anytime your clinic is open, you have to have a provider in the building. If the patient comes past the waiting room. They finally clarified and said, especially, we know Michigan, you guys get snow here, right? Yeah, a little bit. Yeah, they shut us down if we just even think about snow. I live 90 miles north of Atlanta, so you've seen that in the news. It's not pretty. But they don't want your patients just being left out and calling. They, you know, the nurse practitioner's not there yet, the practitioner's not there yet. They can come into the waiting room as long as someone in your building has BLS. Okay, in the building, BLS, past the waiting room, a provider. Now they can be in the break room eating donuts, but they have to be in the building. Got it? Everybody nodding with me? Yes. Okay. They're going to look at your, you know, this number 5, the staff is sufficient to provide services. That one, I've been asked, you know, how do they look at that? I've really never seen surveyors dig into that. What they're going to do is they're going to go and they're just going to observe your clinic. Do you have the staff to do what you need to be doing that day? When they're in your clinic and they're observing, just know that they are observing infection control. They are watching, are your providers washing their hands? They're watching the wipe down of the room. Some of the surveying entities will actually interview a patient. They're looking at lines of sight to see if any of those 4 things are unlocked. So that's back to the physical plant, but that's really where the meat of this is. And number 6 is just what we went through with in the building, in the waiting room, somebody has to have BLS. Past the waiting room, you have to have a provider. Again, I'm a boil it down kind of girl. Back to these regulations, they have to have a physician, and I am going to barely touch on this because the queen of all things policies and chart reviews is going to talk to you. She is awesome. And as she was telling you, her degree's in education, so she has this heart of a teacher. I'm an accountant, so I'm just winging it at this point, but she knows really how to teach this stuff in a way that's very systematic, and I hope will be beneficial to you today. The regulations say that you have to have a medical director, talks about the fact that they have to do chart reviews, they have to be available for consultation, they have to participate in the development of policies, and we're going to get into that. And there has to be a periodic review of patient health records, which Tressa is going to give you tools, timelines on how that has to happen. I'm just showing you the why. your clinic, this is the law, has to show that you arrange or refer patients needed services. So what that looks like is, and I'm going to go back. Let's hit on this. Refer patients as needed for the services. Also, I just wanted to say there is, if you look, and then we'll get into the referral. If you were to actually pull up the regulations, that COVID-19 is still in there. But we have seen, I have memos from CMS with that COVID vaccination has been rescinded. It actually became effective this week or last weekend. Okay, so again, I'm not going to get into all that she has to do. Let's see what we got. We got 30 minutes left. Good. Organizational chart, job descriptions. This is all part of an HR review. So how we get this piece done is, and we've got checklists. I know TCT's got checklists, meaning the compliance team. LA has checklists. We can share those with you. They're great. So basically what you're going to want to do is make sure that if you do an HR review using one of these tools, each year you're going to get this stuff. Okay, make sure your org chart is up to date. You're going to get that by doing an emergency preparedness review. Everybody knows the EOPs and the nightmare that those can be. You're going to be sure that you've got current licenses. You don't want a surveyor coming in and finding out licenses have expired. So if you do that HR review, you've got to have a process. Whether you have, some of the health systems, they've got, really great software that gets that done for you, pops up. But if not, what did you call them? The whistles? Have you a whistle? And we all have them. One of those people in your clinic that just has the organizational skills of a military. Get that person to watch it.
Julie, we do have one question in the chat. And it says, I will have a clinic without a physician on site. Is this acceptable?
Yes. Yes. Those requirements were removed a few years back where they don't have to be on site, but they do have to be. There's so much that can be done via telehealth these days, but there are still going to be chart reviews and availability requirements for them. They don't have to be on site anymore. Chart reviews and availability. Anything you want to add to that?
I will say some state surveyors still do not adhere to the not having practice at all. But many entities are both allowed for remote only.
What have you seen in Michigan? She's saying some state entities still want a provider to be on site.
I haven't had that feedback on Michigan.
Yeah, I haven't seen that in Michigan at all. But yeah, so I tell you what, especially when you get state surveyors, I feel like state surveyors, because they do so much, their job is not just rural health clinics. If something sounds off to you, that's when you call your consultant, because a lot of us will just be able to, because we've done this many times, and we just feed you the guidance that says you can't do that. And if you do it kindly, respectfully, normally that will work, because just because they say it doesn't mean it has to happen. There are ways to educate them, because they may have just come off of a JCO audit where they just did a nursing home and they still have that in their brain and they're still looking for that. And we have to gently guide them back to the rural health clinic world. Great things to have. Going back to, you have to ensure that you can refer and they're being accepted. There are two loops you want to close in a rural health clinic. You want to close the referral loop and you want to close the lab loop. So when you guys are looking and doing your administrative chart reviews, when you guys are looking at your practice as a whole, when a referral is being made, are you sure that you're getting the notes back from the doctor when they see them? Are you sure that the patient is getting an appointment at that cardiologist. As far as being seen, you just can prove that you can send them to the emergency room in the building, and that'll work. If you've got some memorandums of understanding, those are better. The lab loop, when a lab is done, you want to be sure that the lab result is viewed by the practitioner and communicated to the patient. That lab loop is closed. Follow that through, because those can be, for one thing, it puts your clinic at a high liability. If you had a very bad, and I know there's a more medical term to this, critical, if you had a critical lab, thank you, and you did not report it to the patient because your process is broken, then you have some risk for your facility, let alone the surveyors are going to be looking to be sure that these loops are closed. Provision of services. Okay. Before we get into it, here in the room, we have 6 labs we have to do in an RHC. Ladies and gentlemen, men, what do we got? Test. This is your test. What are the 6 required labs? Right now, they're required in the 4 walls to be, you have to have competencies and supplies at least to do them in the 4 walls. Hoping to get, I mean, I can't, prompt access where you can send them next door, but right now, what are the 6? What are the 6 lab tests? Glucose, yes. Hemoglobin, stool test. All right, hold on. She's our star student, and we'll see. Is anybody else before we let her finish out? HCG, pregnancy. Strep, which is primary culturing. What do we miss? Your analysis. That's right. Yes, those are the 6 that you have to have competencies and supplies to do them in your clinic. Even if you send them out, you have to have competencies and supplies to do the current supplies to do them in your clinic. And those are the 6 required tests.
One thing we have caught, clinics have been caught up in, is that they don't have the point of care version of those tests. They, especially the stool cold, they just do the send out. And so you have to be able to result in-house for those 6 tests.
So she said they don't, where our clinics are getting caught right now is they don't have the point of care version of that test, like stool cold. They can send it out, but they cannot, you have to be able to resolve those in-house. They're point of care testing. We're working on it at a national level to get that where that goes away, but that's where we sit right now because it's in the law that you be able to do that.
We did have a star student online as well. So
Ooh,
yes,
all right.
great job.
You have to have policies. Okay, these are just your things you got to do. First of all, let's go back. We talked about the lab. I wanted to get there because I knew one of the later slides actually listed them. So I wanted the test before the answers. Primarily engaged. This is something else they're working on at a national level, but right now, primarily engaged, that's where your 51% primary care. Who understands when I say you have to be 51% primary care? Okay, it's one of those RHC nuances. Basically, you have to be primarily engaged, that's where 51%, in providing those healthcare services at the point of entry into the healthcare system. You cannot be more than 50% behavioral health, primary care.
Julie, real quickly,
Yes.
back to the point of care testing. It
Yes.
doesn't have to be a strep test, though.
No.
It just has to be a culture.
Yeah, primary culturing is the thing.
Okay,
Strep is how we meet it.
correct.
Primary culturing, yes. It's probably the most common thing we see to meet it, but it's being able to primary culture or send out. Talked about primarily engaged. All right, so the policies have to have 3 signatures. I am not going to get into that. We are going to, again, let the queen do her job. what she is so good at. The policies, and the reason I'm gonna go over this is just because you have a whole session on this, but just know the things that she's giving you in this session, it's because it's in the law. This is the section that talks about why you have to have policies that describe the services that you give. You have to just have one that says, this is what we do. How are we going to medical management? I will let her go into, I mean, I've seen something as simple as we use UpToDate.com, which I think is fantastic. Because we had a clinic in Kentucky. Apparently Kentucky has an HIV law for disclosures to that patient, or what you have to do, what you have to say. And this surveyor knew that. And so that's their thing to try to get this clinic. But our policy said that they followed UpToDate.com. And UpToDate.com had the most recent Kentucky things, requirements. And so they were able to pass that survey without the trick question, because that's what I feel like it was. Because they said, okay, our policy says we use UpToDate. They pulled UpToDate and says, well, if this happened, we would notify this, we would give them these instructions, exactly what was required. But why they had to have it has to do with the law, guidelines for medical management, how you're going to store your drugs and biologicals. That you're going to have these things in your patient note, in your blank medical record. That we're going to have these 6 labs, which our star student, you were there, I know you had them. That you have an emergency kit. Everybody knows what an emergency kit is in a rural health clinic. I went in I have a clinic, it's like a quick care clinic in my little town of Ringgold, Georgia. And I don't know whether they're a rural health clinic or not. I know we've got some rural spots, but I saw an emergency kit and I'm like, I know what you are. And it has to have certain things. This is where we get, okay, required, recommended. This is where we get the differences between Quad A, TCT, and the state. If you're with the compliance team, they let you define what's in your emergency kit based upon what your medical director thinks is appropriate.
That's thankfully been expanded to allow for all surveyors. The language was updated to defer to the medical director.
Language has been updated to defer to the medical director. So if you have a state surveyor that's trying to go back to that, Tressa's your girl.
I can send you a list.
She can send you a list. She can send you the regulation that defers to the medical director. Because they used to have some things in there that were just hard to keep. Snakes or snake venom, for one. It was hard. But you have to have an emergency kit. You have to have arrangements. You have to be able to show that they will be accepted if you send them to the hospital. Do that through policies, do that through agreements. For your lab, make sure that you have a CLIA waiver, at least. For those, because they are waived tests, the 6 are waived tests. And that you have a waste management agreement for how your biohead. Please, please, please do not let the medical director take it home in his car. They don't make this stuff up. They don't. That you have the signatures that Trust is going to go through required on your policies. That you've done your chart reviews that she's going to walk you through how to do. That you have written policies on your patient health records. That you're looking at all the things you should be looking at within your patient records. Are you doing social data? I think that's the one that we're seeing most. Here it is. This is the regulation. It says social data. Find out if they're smoking, non-smoking. You have a child, who do they live with? Grab some social data. If you have a consent form, I think the biggest thing, and stepping in here because she does a little bit more of this than I do. that if it's a child that you have a relationship with patient on there? Are you being sure that the person bringing them in has the ability or the consent of the parent to bring them in? Maintaining your records, protection of those records, written policy, and again, anything that says written policy and procedures, we're gonna cover in that specific section, but this is why. These are just some minimum things that you have to have in those medical records. So we're through number 10, which she told you she was going to do 10, she's going to do 11, she's going to do 12. All I'm going to do is tell you why she's doing 10, 11, and 12. So 10 is more about medical records, policies. 11 is the required program evaluation. It's required every 2 years, biennial, not biannual. By that was hard for me to get, biennial with an E. Required every 2, I recommend every year, because I think this is a good idea. I think it's a good idea to look at your clinic every year, what your visit volume is, what your top diagnosis codes are, what are you seeing as far as your number of patients? Make sure that your clinical records are reviewed. I would do that in a quarterly, I'm sure she's going to go through this, in a quarterly meeting, and then bring those to an end. You don't want to wait 2 years before you look at these things. If you miss it, okay. Here's the kicker. Whatever your policy says you're going to do, you have to do that. So although they moved to 2 years, if you have not updated your policy and your policy still says that you are going to do it every year, you're going to get a fine. Because it 2 years for whatever your policy says, and it's less. So everybody go home and check your policy. Make sure you've updated your policy to every 2 years. I think it's a good idea for these reasons. Do we have the right staff? Did we follow our policies? What changes do we need? This world moves faster than we all thought it ever could. Every 2 years, in my opinion, recommended, not required. Let's take a peek every year. The one thing about the annual meeting and that I have loved is the fact that if you do it as more than just checking a box and you really pull your players, you can learn things you've never learned. And you might be in a situation where you have that open communication, but sometimes if you sit down and make an appointment to talk about it, people will sit and they'll talk about it. And they will tell you things you never did, whether it's getting all your providers together. What are you seeing? What are the needs of the community? What are we not doing? What services are you seeing that is on an uptick? And they will be able to tell you. The other thing, and this is maybe not in this topic, is if you're having workflow issues in your clinic, ask your receptionist. Ask your MAs for true and open, however, whether it's anonymous or interviews. What's going on? They'll tell you. They absolutely will tell you. They're not going to offer that. But sometimes the people that just work right there, they've got the solution for you if you would just ask. You're gonna have how to get this done. You're gonna have to have policies. Compliance plan, annual meeting. Number 12, wrapping it up, is emergency preparedness. Whoop, whoop, we all love that, don't we? EOPs, risk assessments. This is as boiled down as you're gonna have to get it. You have to have a plan. You have to have policies and procedures that relate to that plan. Detail woman, queen, she'll go through that. Not just, you have to have the basic ones that everybody has: fire, tornado, medication handling. And then you actually do a risk assessment. And you have to have policies on your top 5 risks. Your communication plan, how are you going to get a hold of everybody in your clinic? How are you going to get a hold of everybody up to FEMA? Training and testing. Yeah. This is your lady right here. I get lost. I don't know if you guys get lost, but I get lost in the training cycles and the required tests and the community tests and the, so I'm not even going to pretend like I have that committed to memory. I do not. And how we deal with integrated healthcare systems, because if you are an integrated healthcare system, I think the one thing I want to tell you here is you can be part of their plan, but you need to be listed in their plan. Do you have anything else you want to mention now, or you want to say it?
So, I really focus, our later session is really gonna focus in on that training and testing cycle.
Because that's where we get the most questions. That's the ongoing maintenance that we have to do. And really, we just want to boil it down to, what do I have to do next? What is coming up next? So that's really what we're going to focus on later in the afternoon. But within the emergency preparedness program, the thing that we catch as an issue most often is, especially if you're participating in an integrated plan, making sure each separately certified facility, your RHC, even if it's in the building of the hospital, has its own unique HPA risk assessment. And we would recommend putting in the name of the clinic and the year that it was conducted, and update that every 2 years to show that you're meeting that 2-year review cycle requirement. So that's probably the thing we find most often is the clinic says, well, we're in the hospital. Our risks are the same as the hospital, which it may be a duplicate, but you still, as a separately certified facility, an RHC, you do want to make sure that each facility has its own risk assessment tool available. And then emerging diseases are included in that review.
Everybody, make sure your name's on it. They don't just say we've got you. All right. I'm 8 minutes early. Questions? Didn't lose my voice, honey and hot tea. Yes, ma'am.
So if we have a rural health clinic and they are
To perform your point of care tests, if there is a lab within your clinic that is staffed by the hospital lab, and they do your point of care tests, is that compliant?
It is not. So she asked, well, you heard, she asked if you have a hospital lab embedded in your clinic and they do it. No. It is not. And I actually had to research that once because it just makes no sense, right? If it's built through the hospital, all of that. But when you dig down, and I hate it, we all hate it, and that's why we're trying to get it changed legislative. Because it's in the law. How I would do that, honestly, is okay, so I've got a clinic, here's how they did it. They had a cabinet. And this is how we get around it. They had a cabinet. Had current supplies for all 6 tests. Had 2 of the MA, once a year did competencies. They didn't change anything they did. They were able to check the box. Because it has to be, I looked at that and it's like by employees of the clinic. It actually, in the guidance, says employees of the clinic.
I would double check to the CLIA and make sure that the RHC has included.
Yes, double check. Ooh, yes. Make sure that the RHC has that clear waiver, that blue license looking document. Because in your case, if it's the hospital that has it, they're gonna have their CLIA. You have to have yours. So put it in that same cabinet on the inside of that cabinet where right outside the cabinet. Perfect. Well, thank you. Oh, yes, ma'am.
Collaborative agreements with our provider.
Collaborative agreements with your provider.
Yes, so if we have, is it enough to have a collaborative agreement with your APPs with the lead physician only, or do they need one with each physician in practice?
I would defer to state law. Because it's not an RHC requirement to have collaboratives. In Wyoming, you don't have to, they're full scope. It is really, what does the state of Michigan require in any clinic? Or what does your, it's really state law at that point. Does that make sense? Not an RHC law, it's state law.
There's an RHC law on requirement for chart review.
Is there an RHC law on requirement for chart review? Yes, there is.
Makes that make sense.
We will go into it. And
It's on the agenda.
right, it depends. But she has slides that actually, we'll put that one in the parking lot for just a minute, but yes. And we will absolutely give you the resources you need to make those determinations. There's an administrative one, and there's a collaborative one. And again, the queen of all things is going to address that absolutely for you. Yes, ma'am.
We have a medical building that has six different clinics, and then
A medical building, 6
a
clinics.
medical building is the RHC.
Okay,
Each clinic needs to do all 6 of the clinic there.
okay, she has a medical building.
Yes, medical building, which is the RHC, so that's the certified.
So the medical building is the RHC.
Yeah, that's your 4 walls.
Okay,
And then inside are 6 separate clinics, so the urology, family practice, peds.
one RHC,
Yes,
somewhere in the building.
so just somewhere in the building.
Somewhere in the
someone
building.
has to do 1 of the 6.
Right, because I was in a clinic that had, I mean, just pods on daily, and we had the HCG and the OB clinic. We had, the urinalysis, and it just had to be somewhere. You had to be able to find it somewhere. Now, the emergency kit, you want in one little grab and go if you can, whether it's a cart or a tackle box. You want that to be condensed. That is for the surveying entities required. I know some states will allow it to be scattered a little bit, but for the labs, it can be scattered. I haven't seen anybody say all over the place. No. Is he online?
No, ma'am.
All right, thank you.
Well, thank you, Ms. Julie. As always,